Is Michael Wright. I'm the chair of Central Eastern Sydney Primary Health Network. I'm going to be the facilitator for tonight's webinar. And welcome. We're basically providing an update about the COVID-19 outbreak and key challenges ahead. We've got a lot to cover. A lot's been happening in general practice and in the COVID vaccination space over the last week. There's lots of changes that we want to update you on, and we've got two speakers. So the first one, we're going to get a public health unit update from Dr Vicky Sheppeard. Vicky's the acting director of South East Sydney Local Health District Public Health Unit. And Vicky, I'll hand over to you.
Thanks very much, Michael, and good evening. Sorry about that. Put my phone to mute. Okay, I'm sorry about that. Yeah, I look very pleased to have a chance to share information with you all this evening in what's been a very rapidly developing situation. So, in fact, I think it's Wednesday today, so it was just 2 weeks ago that our first case in this COVID cluster was notified. As I'm sure you're all aware, this occurred in a person who was driving international flight crew between the airport and their accommodation, their quarantine accommodation. And unfortunately, this person was quite infectious and has seeded this outbreak. So the important thing about this outbreak and the difference to the situation we had in 2020 is that this is an outbreak of the Delta variant of COVID-19, and we're finding that it is, well, at least twice as infectious as the outbreaks that we had last year with the Wuhan original strain of COVID. So what we're finding is that the infection is spreading through quite transient contact with people. So when we were very much following up in detail cases 2 weeks ago, we received CCTV footage which demonstrated that this infectious person really just walked by somebody in Maya as you would in any shopping aisle, and just past the person, and that was enough to spread the infection. Not to say that it's always spread like that, but we have seen several examples of that. And the other thing that we're seeing is a lot of spread within households. So really, once someone in the household has the infection, it's really the other people are coming down with it and being confirmed cases in the next few days. So it is a bigger challenge than the COVID outbreak we had last year to bring under control. So we've had, so I can speak about Southeastern Sydney, which I know the best, and I'm aware some of you from Sydney, local health district. But in Southeastern Sydney, our cases have ranged between 3 and 89 years of age. I think we've at the moment got 3 or 4 people in hospital. We've had 3 in intensive care so far. Overall, the numbers are changing pretty rapidly, and I guess it's best to stick to what comes out in the daily numbers. So today, when we issued our report up to 8 o'clock last night, the cluster stood at 171. And of those, 105 are in the Southeastern Sydney district. Most of those are in Waverley is the most affected local government area, followed by Randwick, Wallara, and to a lesser extent Bayside. And obviously there's cases in the City of Sydney, Inner West, and other neighbouring local government areas. One of the disappointing, there's been a couple of worrying things that have contributed to making this outbreak more extensive than it need have been. We've had a number of, as I said, older people, affected people in their 70s and 80s, and none of them been vaccinated. And, you know, I don't know why that's the case, and it would be good to hear your views on that. It's a real pity they hadn't been vaccinated. And similarly, amongst that age group, there's been a lot of delay in diagnosis. So they've had symptoms, but they haven't been seeking testing. So this has meant that they're spending time with their families and have infected their family members. This has then introduced the infection into workplaces, and we know that workplaces the infection can very readily spread there. So I think that those are a couple of talking points that would be good to draw out tonight, is about how we can encourage the vulnerable elderly to get vaccinated, and also have the older people presenting for testing. They've always been tested at a much lower rate than young adults and children, for example. So early identification is important, so getting the message out to your patients, particularly if they're in the affected areas, but also more broadly anywhere in Sydney, that if they do have respiratory symptoms, the importance of getting a COVID swab, and helping them understand how to do that. And there's many options now, as well as the GP respiratory clinics and the hospital clinics. There's a lot of additional private drive-through testing clinics in the area. So really encouraging people to get tested. I guess the other thing I just wanted to talk about, we unfortunately have a few GPs who are cases or in isolation after being exposed to infectious patients. And from my recollection, all but bar one of those didn't occur because the person presented with COVID. It occurred when the person presented with, for example, one of the transmission cases, the person came in for a skin excision procedure and was unknowingly infectious with COVID at that time. So that GP did acquire the infection from that person. So, and I'm aware that next week you are having a whole webinar on how to protect yourselves and your practice from COVID. But I guess we can't wait a week for that. And I'm sure Margaret Jennings will give excellent advice, but reviewing now your screening procedures, your vaccination of yourself and your staff, having routine contact and droplet precautions for all your patients. I'd be particularly in the eastern suburbs, I would recommend that now. But also, if not using full contact and droplet precautions, certainly a mask for yourselves and your staff. So I think those are the main points that I wanted to cover, but I'm very happy to be taking questions on this and on vaccination as the webinar progresses.
Thanks, Vicky, for that update. Just a couple of questions. You mentioned about the full droplet protection. Like, is PPE, should we, would you recommend that GPs have mask, gloves, eye cover for all patients? I mean, given the increased transmissibility of the Delta variant?
Look, I do think that's a consideration, particularly the mask and the eye protection. To an extent, we can manage gloves with excellent hand hygiene and the gown. But for any patients with respiratory symptoms, I'd recommend the full mask, eye protection, gloves, and a gown. But for people without symptoms of COVID, routine patients, I would certainly be strongly considering both eye protection and a mask.
And we've just had a couple of questions asking about sort of N95 and P2 masks. Have you got any sense of, I mean, yeah, is there a difference that we really need to, should we be giving everyone N95 masks now?
So certainly in our hospitals, when there are patients with respiratory symptoms and not yet known whether or not they have COVID, N95 masks are utilised. Otherwise, for patients that don't fit that syndrome, a surgical mask is still employed in hospitals. So I think that would also be applicable to general practice.
Great. And then probably one final question for you at the moment is just about cleaning between, is sort of the practical issues of cleaning between patients. Should we be cleaning Perspex shields? Should we be cleaning all of our consulting room between patients?
I think, yes, you're wiping down between surfaces the patient has touched is mainly for protecting the subsequent patients that might be using the chair or the desk or so forth. So yeah, having a routine wipe down between patients is important. When you're talking about Perspex shields, that's for the...
I think on things on the desktop, that sort of protecting the reception staff.
Yeah, I think the reception staff are not going to come in contact with that. So it's about who's going to come in contact with it after the patient has. So the things that other patients or staff will come in contact with are doorknobs, chair arms, places that patient has touched or another patient's going to touch.
Great. And then just in terms with the Delta strain, just a couple more questions is about I suppose the seriousness of the infection. Do we have any sort of insights of, are people just as likely to be hospitalized or admitted to intensive care?
Yeah, fortunately, it is no more virulent than the Wuhan strain. So, we expect it will continue to have about a 10% mortality for people over 80. But yeah, there's no indications that it's more virulent or more serious. It's just more transmissible. Okay.
And one final one before we move on I'll move on to Brendan just to give us a bit of a vaccine update and open up for more questions. There was one question about asking how do you sort of manage patients who are refusing to doing a COVID test, after they've got hotspot and they've got symptoms and they're practice potentially.
Yeah. So under the Public Health Act, there's the concept of, reasonable suspicion of a Schedule 4 condition. So COVID, TB, HIV are Schedule 4 conditions. So if we can form a view that we have a reasonable suspicion that a person has COVID, then under the Public Health Act, we can require a test. That's not something that's done very frequently. I think we did it once or twice last year. But if someone came to you with the constellation of symptoms, and particularly if you could elicit that they'd been to a hotspot, a known contact site, then that could form a reasonable suspicion they had COVID. So I think you'd need to call the public health unit to discuss that. So it's not something we're going to be able to do frequently. So it's just got to meet that legal barrier that we can do that. But obviously, discussing with your patient, the risk to others if they go undiagnosed, etc., would be the first steps to go through, bringing in other support. So if it's a culturally and linguistically diverse person, Aboriginal, we'd need to bring in those supports around the person first before we went to the full step of using the Public Health Act.
That's great. So there's a number of steps before hopefully you ever get to that point, but it's good to know there is a potential public health route to help you. Thanks, Vicky. I might hand over to Brendan to give us a brief update about the vaccine rollout, and then we do have a lot of questions about that and more questions for you. Brendan's, as many of you will know, he's the General Manager for Primary Care Improvement at CESPHN. I'll I'll hand over to Brendan.
Thank you for that, Michael, and good evening, everyone. Just to give you a bit of an update in terms of what's happening in our local region within the context of all that's going on nationally. Well, it all began back in late January, February, where the COVID-19 vaccine national rollout strategy was put out, and no doubt many of you are familiar with this. 5 major phases covering the different population groups within Australia, with those who are most vulnerable aiming to get vaccinated first. Now, in terms of where we are now progressing from that national strategy, well, so far there's been about 7.5 million total vaccine doses that have been administered. This is at the 28th of June. And there's been about 126,000 in the last 24 hours or so. Now, of that 7.5 million or so doses, the Commonwealth have delivered 4.3 million, and that's broken down a bit further in terms of about 3.9 million, or almost 4 million, being delivered in primary care, which is a fantastic effort, and about 430,000 that's being delivered in residential aged care and also in disability. And when we have a look at the 3.162 million that's been delivered by the state and territories, you can see that New South Wales is standing at about 809,000 and have done nearly 20-odd thousand vaccinations in the last 24 hours. I think this next graph is very interesting. What it shows, I think, is the relative proportions of the vaccinations being delivered by GPs, by general practice respiratory clinics, and by Aboriginal community-controlled health organisations. And of course, those being done in RSFs and disability. And of course, in the dark blue, at the very bottom there, is that being done in jurisdictions. And I think what this graph shows is not only the relative proportions, but of course, the speed by which primary care took up the challenge of responding and delivering COVID-19 vaccinations. You can see a very, very steep and continuing curve up that. And I think that's all credit to general practice. In terms of primary care vaccinations now by state, in terms of the total number of vaccinations being delivered in primary care, it's about 3.9 million doses, of which New South Wales has done almost a third, that is 1.2 million. And clearly, I hope there's no one from other states sort of zooming in, but clearly New South Wales is leading the pack in terms of having 1.2 million doses administered. And that's a pretty fantastic effort. Now, in terms of Australia's vaccination progress, it's pretty easy to summarise. And for those of you with poor eyesight, well, let me give you a top tip. It's right down the very bottom. 4.68% of Australia's population has been fully vaccinated against COVID. And we can see at the very top is Israel, Chile, Iceland, Hungary, United Kingdom, and the United States leading the pack so far. So Australia right at the bottom. So I guess what you'd say is room to improve, and we need to improve rapidly. So in terms of the national updates, well, I'll just move my screen slightly here, everyone. There we are. I can see it a bit better now. In terms of some of the big announcements, all adults aged 40 to 49 and are eligible for the COVID-19 vaccine was announced. Targi announced on the 17th of June that Pfizer was the preferred vaccine for anyone aged 50 to 59. And of course, we know that created significant implications for general practice and also contributed to vaccine hesitancy. Then on the 28th of June, just a couple of days ago, the government announced access to AstraZeneca would be expanded to adults under 40. Now, of course, that's been in the media a lot today, but it's all based on so long as those patients give informed consent. And again, much media on that today. Just turning now, I've sort of covered the big picture nationally. I just want to turn into our region now. So as of the latest data that we've got, which is the 27th of June, we have about 323,495 doses of COVID-19 vaccine that's been administered in the CESPHN region. CESPHN region being that of Sydney Local Health District and South East Sydney Local Health District. And of that, around about 60% has been delivered via AstraZeneca, and the remainder, 41% by Pfizer. In the last week, there's been an additional 25,000 or nearly 26,000 doses of COVID-19 vaccines being delivered in the CESPHN region. And I think what you can see is the continual increase of vaccination uptake in our region. There was, again, an 11% increase in the number of COVID vaccine doses delivered in the previous week from the CESPHN region. So again, we're gearing up. And in the last week, sorry, just going to move this. So in the last week, we saw an increase in the COVID vaccines doses being administered across all age groups, with the exception of the 50 to 59 years. And that's perhaps attributable to the vaccine hesitancy arising from the ATAGI announcement that Pfizer is now the preferred vaccine for this age group. And I sort of mentioned that earlier. Some of you are no doubt thinking, so what's ahead? Well, it's a bit of a crystal ball, but this is what the federal government have announced. What they've said, and we all know that there's strong uptake of Pfizer and strong demand for Pfizer. And so you can see there that Pfizer is projected to be vaccine used in Australia until August. But then increasingly though, and it'll go through, but increasingly though, what we'll see is more and more doses of Pfizer and the introduction of the Moderna vaccine. So again, AstraZeneca through until at least September, increasing amounts of Pfizer up until about 530,000 doses from October to December, and the introduction of a new vaccine, Moderna. And of course, just to note too on aged care and disability, ongoing vaccinations for those really key vulnerable population groups. It's no surprise this graph, quite frankly, which is that those aged 60 to 69 years are the highest, are the age group who have had the most amount of vaccines that's been administered. So nearly 46% of that age group, 60 to 69 years, have been vaccinated. And that's a pretty good result. Still, we've got a lot more to go, but it's promising, and it shows you about what lies ahead. Also to note too that those aged 50 to 59 are also fairly keen vaccinators as well. Can I just put a bit of a plug in now for Eligibility Checker? And it's updated frequently as new practices come on board, particularly those practices who are participating in getting Pfizer. So please recommend it to your patients, bookmark it, put it on your website. And don't forget to update your practice information, and you can contact our fantastic practice support officers in the PHN who can help you with that. So Eligibility Checker is a really key tool, both for your patients, but also for your practice. So in terms of general practice within our Central and Eastern Sydney PHN region, we've got about 363 odd general practices who are participating. This includes the 82 practices who commenced this month. We've got a further 80 practices who have been approved to administer the Pfizer vaccine from July, and we brought that forward in part because of the latest outbreak. And we certainly expect more practices to come on board administering Pfizer in the not too distant future. In part, that is related to the supply of the Pfizer vaccine. 40% of those who applied have been approved for the July start. And again, as I've mentioned, as vaccine stock increases, particularly in relation to Pfizer, more practices will be approved to participate. We shouldn't forget our general practice respiratory clinics who've been absolutely key in responding to the COVID-19 pandemic. We have 5 general practice respiratory clinics, including a mobile clinic that targets those who are homeless or those in other precarious positions. All are offering AstraZeneca vaccine, and they'll soon be commencing Pfizer vaccine in July. Just a small note that people without a Medicare card should be referred to here or to the state vaccination clinics. Now, in terms of the delivery of the vaccines in our region, we've got two major hubs, or three major hubs. Sydney Olympic Park, that can vaccinate up to 7,000 people a day, which is quite extraordinary. It's a very efficient operation. We've got RPA Hospital at Mallet Street is able to vaccinate nearly 2,000 people a day, and the St George Hospital, they can do somewhere between 900 to 1,000 people a day. And of course, always looking to try to increase capacity in each one of these state vaccination clinics. Just to note the eligibility for AstraZeneca, and I'm sure Vicky will make some comments around this as well, that all adults need to obtain a fully informed consent for those aged under 60 years old who want the AstraZeneca. And of course, check the eligibility checker for any updated changes on that. Okay. In terms of the eligibility for Pfizer, it's really adults aged 50 to 59, Aboriginal and Torres Strait Islander people aged over 16 years, and of course residents and staff of residential aged care facilities. That's critical and high-risk workers, healthcare workers, people over 16 with underlying medical condition, including those in NDS, and carers and disability workers. The aged care facilities update, and I'm almost bringing my presentation to a close now, which is that it'll be mandatory for workers in residential aged care facilities to have to be vaccinated for COVID-19. We've got nearly all of our RSCFs have completed both doses of the COVID-19 vaccine. And we've also started up with the Commonwealth roving clinics. We had 2 vaccinated last week. We've got Healthcare Australia who are doing now literally 10, or a bit over 10 per day. And they'll be vaccinating residents, but importantly, staff across the region in RSCFs. We've got about 149 odd disability group homes within CESPHN. It's probably fair to say that this rollout has been delayed, and that's obviously of concern. The Commonwealth have appointed a vaccinator for those disability residents who are not able to leave the disability group homes. The vaccinator has been appointed, but the rollout has been slow. And so certainly as a PHN, we've been working really hard with the Commonwealth and really trying to advocate very strongly for the needs of those staff and residents in disability group homes, knowing that they are particularly vulnerable and there's still a lot more work to be done. At the end of, you can see a list of links and resources that I've put up as part of our contribution. And I suggest that they're all a range of different sites here that are worthwhile bookmarking. And can also put in a plug for our webinar next Monday night, which is titled Keeping You and Your Practice Safe or Still Seeing Patients. Next Monday night, it's free. It's a Zoom webinar from 7 o'clock to 8 o'clock, and we've attached the registration details there. Michael, happy to hand back to you.
Thanks, Brendan. Thanks for giving that bit of an update. And we do have a lot of questions about the vaccine rollout. So we'll start getting into those. Vicky, did you have any comments? I suppose one of the first questions, there's a couple of clinical people asking the idea about, what your opinions are of giving people aged under 40 the Pfizer jab and what might it entail to give them, informed consent from the point of view of the medical indemnity. Mm-hmm. Would you be able to comment on that?
Yeah, look, it's obviously a very complex question. So there's just a very few conditions that have been predisposing to the thrombosis and thrombocytopenia syndrome. So that's antiphospholipid syndrome, prior cerebral venous thrombosis, prior significant abdominal splenic vein thrombosis, etc. So apart from that, the cases which we have been in otherwise well people. And so as the data has accumulated since the rollout of the program, the rate of TTS or thrombosis with thrombocytopenia or vaccine-associated thrombosis and thrombocytopenia is about 3 per 100,000 in people under 60 years of age, and about 1 per 100,000 in people 60 years and over. So it remains a very rare complication, but that doesn't mean that that's an easy risk-benefit discussion to have with your patients. And I think the risk-benefit does vary according to the person's risk and also the consequences of them catching COVID. So at the moment, we are in this particular area, at the highest risk of catching COVID that we have been in for probably 12 months. And so people who are able to stay at home, not mix with others, well, their risk is low. If it's someone who needs to be out and about working, particularly health workers, for example, they are going to have the chance of encountering. And then it's the individual susceptibility. So if the person has underlying heart conditions, asthma, other things that would predispose them to severe COVID, well, then that would push them towards that very rare risk of 3 in 100,000 of TTS compared to the very prescient risk of COVID. So I guess that's the kind of discussion to have with your patients. And the other really important discussion is that if they do accept AstraZeneca vaccination, is what to look out for. And important to emphasize that it's from 4 days to 30 days to be looking out for the headache, the abdominal pain, the chest pain, the shortness of breath, and to come back and to see you if those symptoms develop, or go to the emergency department. The important thing then is to do the assessment, a full blood count and a D-dimer. And even if it's negative the first time, check again the next day if you're concerned about the patient, because some of the patients with this syndrome, when they're first assessed after presenting with the headache or abdominal pain, they've got a platelet count in the normal range, 160,000 or something. What we find then is the next day, if they're tested again, the platelets are dropping. Or you may have pre-existing knowledge of their usual platelet level. So if it's less than that, even within the normal range, then that's a trigger to get in contact with a hematologist. Because the good thing about TTS is that if it's detected early and treated correctly, then the severe consequences can be avoided. So it's there's a lot to take into account, but I guess those are the kinds of discussions that people are encouraged to have with their GPs to weigh up the risks and benefits.
No, thanks, Vicky. That's really helpful. I think you'll see a few links being posted. We posted the link to the ATAGI advice that sort of outlines the risk per decade. We've posted a link. The RACGP did a webinar last week about TTS, which sort of goes through sort of some practical steps, and a couple of other links. So hopefully that clarifies, which at least would give people some more comfort in knowing statistics before if they did decide to prescribe it. We've had, and I'm going to throw into a few things for Brendan, but Vicky, there's just a few questions we've had about sort of combination vaccines. So you've got a patient who's had one AZ, who's potentially resistant about having the second one. What would you do for that? And would there be a benefit in giving them a Pfizer, as a second, if you could?
Yep. So that's a very popular question. So the first thing to say is that someone there's good data in the UK where they've given 20 million or 60 million AstraZeneca doses, some enormous amount. They actually see a lower rate of TTS after the first dose than we do. And we think that because we haven't had COVID here and we've had a very active surveillance system, we've picked up a lot more TTS. But so overall, the UK's seen about 1 in 100,000 cases of TTS after the first dose. And they've only seen about 1 in a million cases after the second dose. So we think that it's 10 times more rare after the second dose of Pfizer. So I think if your patient has successfully had their first dose of Pfizer, that they can safely have their second dose and have an almost infinitesimal chance of this complication. That doesn't mean they still don't need counselling about what to do. So that'd be the first thing. I'd encourage them to finish their course of AstraZeneca. There is certainly emerging evidence on mixed courses. As yet, the Australian Technical Advisory Group and the Therapeutic Goods Administration have that under consideration. So there's no recommendation to do that in Australia at the moment, with the rare exception of someone who's had a serious adverse event to the first dose of AstraZeneca can then have the Pfizer. So I wouldn't routinely be recommending that now. And, you know, I think we're all possibly coming up for booster doses after this. So the best thing at the moment is probably to finish your AstraZeneca course and then have some other options later in this year or early next year about boosting.
Maybe 2 other questions for you, Vicky, probably following on from that. At the moment, there's this 12-week window where we're supposed to wait between the AstraZeneca doses. A lot of patients are saying, look, it's been 8 weeks, can I have it now to get more protection? I suppose I was wanting to know about that. And then secondly, we're starting to hear a few more stories about this myocarditis related to Pfizer. Mm-hmm. And just wondering if you have any insights into that and whether that might, I don't know, tip the needle back towards AstraZeneca. But,
yeah, so the dose spacing. So in the AstraZeneca clinical trials, which were about 30,000 people, there were a variety of dose intervals used. They used a 4-week, an 8-week, a 12-week, and I think a few had a 16-week. So the best efficacy and immunogenicity was obtained with the 12-week interval. That said, at 8 weeks, it was actually pretty good, and it reached 70% efficacy. And very admirable antibody levels were also achieved at that stage. So in Australia, the recommendation was the interval could be between 4 and 12 weeks, and the preference was for 12 weeks. But that was at a time when we didn't have a COVID outbreak. So I'm lucky. I finished my AstraZeneca course about a month ago. But if now where I work, and if I was 8 weeks into it, I would prefer to get my second dose now because that's going to give me a lot of good protection in the coming weeks when I might be exposed to COVID. Whereas if I waited 12 weeks, I might have better long-term protection, but at the moment we've got an immediate risk that we're countering. So if patients are seeking vaccine after 8 weeks, I wouldn't turn them away. There is a bit of if your patients are using state vaccine centres, at the moment, they're not able to offer that flexibility, but certainly in general practice, you can make that assessment. And I think it would be a good thing to do. Your other question was about Pfizer and myocarditis and pericarditis. That's certainly now recognised as an adverse event related to Pfizer. Quite differently, it's occurring in young men mainly, really mainly in the 16 to 25-year-old age group. And interestingly presenting as both myocarditis and pericarditis. So that's we're not routinely vaccinating that age group, but that's something that we're going to have to grapple with as the program extends into that age group. It again remains a very rare complication, a side effect similar to the magnitude, I think, of the TTS. So once again, very rare, but yeah, I think we can grapple with that in the coming months.
It comes. Thanks for that. Vicky, sorry, Brendan, can I just ask you, you mentioned about a number of practices going to start offering Pfizer in July. I know July starts tomorrow, so I'm just wondering, are you expecting the vaccine? I know nothing's certain in this pandemic world, but are you expecting the Pfizer in the next week or two, or sort of is it going to be towards the end of the month?
Oh no, it's starting on the 5th of July. Those initial practices are starting on the 5th, and then progressively roll out over the next couple of weeks from there. But I do think, though, that Pfizer will clearly be extended more into general practice. And we expect the Commonwealth to make some announcements on that fairly soon. Clearly, it's tied up in part to the supply of Pfizer as well.
And I suppose that brings me on to the next question, which is about the quantity of vaccines. We've had a lot of troubles with the AZ rollout, and that some practices have had too little, others have had too much. Is it likely to be similar teething problems with Pfizer, given the transferability of that?
Look, Vicky might be able to comment on that, but clearly there is huge demand for Pfizer. That's outstripping supply. But what we do know, and I think we should focus on the positive here, which is despite that, at the moment, there is going to be more Pfizer doses occurring over the next 2 to 3 months, and so that's what is projected. More Pfizer doses coming, but at the moment, clearly there is a bit of a rate limiter happening in terms of because of the supply of Pfizer.
We've just had a couple of questions. We've had a few questions about the telehealth item numbers. So, as many of you know, the government has changed the telehealth item numbers. The existing telephone item numbers I understand, are going to stop from tonight. So from tomorrow, from the 1st of July, there are 2 different telephone item numbers, which equate with an A and a B item number. The videos continue. I think there are some exceptions for mental health. And I think we'll try and post the link to the updated Medicare item numbers. Now, I'm putting on my other hat with the College of GPs on as well. We've been saying, look, this is really not the right time to be messing around with item numbers. And I don't know if things are just suddenly going to start being rejected from tomorrow. But I think everyone needs to be aware that they're all scheduled to change from tomorrow. Thanks, Natalie, for posting the link for that. Now, we've had a couple of questions about the AstraZeneca consents. Can we use the same consent form for Pfizer as we have for AstraZeneca, or will the PHN be supplying new consent forms? Brendan?
Yeah, so we're just working on that at the moment. Yep, and so hopefully we'll send an update around that in the next few days.
We've got a few questions about the QR code. So many of you will have seen that the state government's announced that all businesses need to have the New South Wales Health QR code, I think from the 11th of July. Do either of you have any clarification? Will that include all medical businesses as well?
So perhaps I can jump in, Vicky, a bit and say, look, we really encourage general practice to have QR codes. We think they're really, really important. It's fine to have the clinical booking system, but people are often accompanied to their appointments by other family members. And therefore, we really encourage the use of QR codes. In our Sydney Health Weekly, that goes out each week, weekly. It goes out on Wednesday. It's around, we have a big focus on COVID. I suggest that you sign up to that because we've just had, we put out today some information on QR codes about how to access them, how to employ them in your practice. So I really encourage practices to take on QR codes. They're really important.
Vicky, anything more to add to that one?
I'd actually also like to make a suggestion that the practice principal or practice manager there's some kind of a out of hours contact number. I had to get Brendan to help me last weekend or the weekend before when we found an infectious patient had been to a general practice that had closed for the weekend, and we certainly were anxious to let the GP know about that. So that's something else that I'd get you to think about, and make sure that the PHN has your an emergency contact number for your practice.
So can I just strongly endorse what Vicky is saying? We have close collaboration with our public health colleagues, and really important to make sure that we've got those emergency mobile numbers, if need be, or contact numbers for GPs. There are only very special circumstances by which we give them out. Public health is one of those. Okay, so if they're asked by Vicky, then it's given out, and you know, that's the right thing to do to protect you and to protect your patients and your practice for that matter as well.
And the QR code for your patients would also be really useful, because that's a system that's working really, really well for contact tracing. So the Service New South Wales is able to give us that list of people who've used a QR code very rapidly. We can then SMS them. So it cuts down the time where they might then be spreading, you know, rather than waiting for practice records to come and things like that, people could already be spreading this infection. So that would be a really great help if practices did have the QR codes, Service New South Wales QR code for their patients.
Great. Just a couple of questions here. I just suggest the PHN email us and we'll gladly provide a contact number.
Yep, or the other option is to, next time, is to contact your practice support officer. But we'll also make arrangements in the next newsletter as a way of mechanism for you to tell us how you can give us your emergency contact details. I would welcome that.
We've just got a couple of questions sort of about prioritising the Pfizer. So there's sort of, you know, people, some over 60s who say they're household contacts to a healthcare worker or a quarantine worker, and they've been prioritised to get Pfizer. Are they still the priority, or are we starting to prioritise younger people? I suppose, Vicky, and now as the sort of mass vaccination centres have picked up, are the criteria fairly, you know, is there sort of a hierarchy of people?
To my knowledge, and I'm mainly familiar with St. George, so they're prioritising healthcare workers themselves. So we still unfortunately have unvaccinated healthcare workers. And that's crucial that healthcare workers are vaccinated. After that, I'm not aware of how they're prioritising other groups, apart from, yeah, obviously border workers, aged care facility workers. These are the key priorities, and we haven't finished that job yet.
Do we have either of you have any sort of insights? When do we think, and what do we think will be pharmacy's role in the vaccination? And then we've got a question about, is AZ going to be stopped in October, given from Brendan's sort of 3-stage thing?
So maybe I can take the pharmacy one if you like, Vicky, and then you can jump in. Certainly at the moment, there are no plans, as far as I'm aware, for pharmacies to get involved in COVID-19 vaccination in New South Wales. I'm aware that they're doing it in Queensland, but not in New South Wales. And again, I'm not aware of any plans to do so.
Yeah, I'm also not aware of any plans. I know the Chief Health Officer is really keen for general practice to have both Pfizer and AstraZeneca vaccines. But these are not decisions made by New South Wales Health, but certainly advocating for general practice to take the lead in vaccinating the community with both vaccines. I can't answer the question about the role for AstraZeneca after October. You know, Moderna have not yet submitted their application to the TGA, so we don't know the timing of that being registered and supplied. And as Michael and Brendan have said, there's also uncertainties about ongoing supply of Pfizer. We hope it will pick up, but we don't, you know, subject to so many complications. So we produce AstraZeneca in Australia. It's a safe and effective vaccine. So I think we'll be continuing to use it in the foreseeable future.
Great. And Vicky, there's sort of a clinical question, and I think a few of us are seeing this. You're sort of getting patients who are calling up who've got early symptoms, who say they've had a COVID test. And just wondering what, how we should approach that. Potentially could their COVID test become positive? Sort of up until now, people have sort of looked at that as sort of being a reassurance by having the negative test.
Yeah, look, I think it goes back to the point we were saying before, is routinely employing these contact and droplet precautions, because whether your patient has had a test that's negative or not, you don't have any surety. So it's about protecting yourself, protecting your practice, but of course, looking after your patients as well. So I think they do need to be seen, and you can take measures that will protect you by getting vaccinated, by having the eye protection and the mask, and when you're assessing these patients. So if a test can be negative one day and the person infectious the next, and as I so we can't be too reliant on tests, and it's about having those protective measures in place for yourself and your staff.
Great, thank you. Brendan, just on the subject of sort of the PPE, can you just give us a bit of an update of, like, does the PHN still have masks or other PPE available for practices?
Yeah, so the important point to note here is that we are very much determined, our supply comes from the Commonwealth National Stockpile, and we very much operate in terms of the guidelines that's set by the Commonwealth on that. And so what the Commonwealth have said to us is that surgical masks can be provided to general practice, and we provide some N95s for those practices who are testing, and we also supply the general practice respiratory clinics with other PPE as well. But again, very much determined by the advice from the Commonwealth. It is them, not the PHN, that sets the parameters for which we can supply.
Great, thanks for that. I'm just going through the list of questions. We've answered a lot, but there's still they're coming quickly. Vicky, is there much? There's just a question about false negatives. So, or can you comment on some of the false negatives or false positives of COVID testing? So, say if someone's symptomatic, if someone did have respiratory symptoms, is the test very sensitive?
Look, it's a highly sensitive and specific test, and my virology colleagues would hate me to say this, but it's not 100%. So once again, that's why we can't only rely on the test result. And we have definitely had people who've had an exposure, they've had a consistent disease, they've consistently tested negative, but when we do their serology, it's positive. This was last year. And so even today, we've had a couple of confirmed cases that just 2 or 3 days ago, while they had the same symptoms, had a negative swab. So there's always going to be, and what are we at? 68,000 tests a day in New South Wales. So even if it's 99.9% positive, there will still be sensitive, there still will be cases that are missed. So yeah, we always need to keep that in mind, but it's an excellent test, and so highly sensitive that it picks up infection, months after it's completed. It finds COVID in sewage when there's 1 in 10,000 people shedding the virus. So it's very sensitive, but not foolproof.
Great. And probably sort of a bit more statistics, just a couple of people have asked about the vaccine efficacy. So how long after the second vaccine are people likely to get sort of their maximum protection?
Yeah.
And is Pfizer better than AstraZeneca, for want of a better comparison?
They both have a similar interval to maximum efficacy, which is about 12 to 14 days after the second dose. But for both of them, even after the first dose, after 12 to 14 days, there was a divergence in the in the efficacy compared to people who weren't vaccinated. So there is some protection for both of them. It kicks in a couple of weeks after the first dose. I guess a benefit for Pfizer is we're getting the second dose quite quickly. So you then have 2 weeks after that, you're fully protected. And the overall efficacy for Pfizer was well in the 90%, depending on the age group, and around about 70% for AstraZeneca, but they were both highly effective in the high 90s, preventing serious disease and death. And that's been borne out in effectiveness studies around the world.
A couple of questions. We're drawing to a close. Just some questions about someone who becomes pregnant after their first vaccine.
That was a good question.
Yeah.
I haven't. So there's a recommendation for Pfizer for pregnant women. If someone's had AstraZeneca as a first dose and then falls pregnant, I would probably call the New South Wales Immunisation Specialist Service to ask that question, because I don't know that answer right off. I imagine that would be a pretty rare circumstance because most women of childbearing age will receive Pfizer anyway, but important to recommend and arrange Pfizer vaccination for pregnant women.
And just one question, sorry, we should have covered this earlier. Are the symptoms with the Delta variant similar? I mean, are there more asymptomatic people, or is it the time to, that it's more transmissible?
Yeah, I think we're seeing a high rate of symptomatic people: headache, sore throat, cough, feeling really rotten, breathlessness, anosmia, agustia.
Any thoughts on if someone does have a negative test but they still have respiratory symptoms, sort of how long should we retest them after a week or a couple of weeks if they've still got symptoms?
Oh, I retest them after a couple of days, particularly if they were, and it's important still here to use your multiplex respiratory panels. We don't have any flu around, but there's lots of paraflu, quite a bit of rhinovirus, adenovirus. So it's good to have an alternate explanation for their symptoms. But if you're worried about someone and they've been in areas of COVID transmission, I'd repeat the test again in a couple of days if they aren't improving.
And at the COVID testing clinics, can we ask for them to do the respiratory panel, or will they just do the COVID test?
Certainly a lot of the privates, I think Histopath and Lavity are very happy to do the full respiratory as well as the, and obviously if the GP orders it anywhere, they will do it. Yeah.
Oh, no, I mean more the respiratory clinic. So say if we ask a patient to go to, say the testing, like a COVID swab clinic set up by St Vincent's, can we ask them to do the respiratory panel?
Yeah, I think if you put a note, give the patient a note, they would be happy to do that as well. Yeah.
Oh, great. Now, we are running out of time. We've still got a lot of questions. I might just, if you've got a few minutes, I'll just quickly run through a few more. Now, Natalie or Michael Moore, are there any that I've missed that we need to answer?
No, I don't think so. There's a few that we've kind of answered online, so people can see the answers to them online. I mean, there's some interesting discussions about the AstraZeneca risk, and so we've sent a few links there, which put the risk in some kind of way that people can understand. I mean, the thing that sticks in my mind is that the risk of dying from AstraZeneca vaccination is about the same risk as being struck by lightning in the next 12 months, or another way of looking at it is it's some 1/50th of the risk of getting killed in a car accident. So if you're very concerned about dying in the next 12 months, AstraZeneca is not the thing you should be avoiding. It's motor vehicles.
And on that note, Vicky, Brendan, any fight? Look, once again, it's a bit of deja webinar. I think, when we think, say 15 months ago, we were having this saying the situation is rapidly changing and we're getting updates, every day. And I think we're back in a similar position. So I think the important thing is that the PHN is still gathering the information, posting the links to the updated information, as are the public health units. And we are here to provide, information, and we'll continue to provide these webinars. Vicky or Brendan, is there anything else that you think we should know?
Yes, could I just encourage people to get along to the webinar next Monday night? There really will be a really practical webinar on again COVID-19 in your practice and how to keep operating. So please join that webinar. All right.
Any final thoughts from you, Vicky?
No, Michael, just, yes, please encourage all eligible people to get vaccinated and tested if they have symptoms.
Yeah.
Michael, can I just jump in with regard to the QR codes? One thing that should be mentioned is that it actually is mandatory as of the 12th of July. So it's not mandatory at the moment. We just encourage practices to do it because it's more efficient and because it helps the public health units. But as of the 12th of July, it'll be mandatory for all businesses. There was a question about what happens if you do home visits, and it doesn't apply, I wouldn't have thought, to home visits, because it applies to workplaces. And so if you're doing home visits, then obviously you're going to have to keep very good records, but it doesn't apply to home visiting businesses.
Great. Thanks for that extra information, Michael. And thank you all for attending tonight. Hope that was useful, and we will update you again further. Thank you, Vicky. Thank you, Brendan, for your insights and for sharing so much, covering so much ground in such a short time. A little link to the evaluation will appear any minute.